All right, good morning, ladies and gentlemen, and good morning to this edition of our daily webinar. Every day there's something interesting. It's very diverse, but today we're talking health. And we're talking health with the Independent Evaluation Office. Oscar will do the honors, of course, but I discovered the Evaluation Office after a long time in UNDP. I discovered they're actually producing very interesting short stuff. And the short part is where he caught me, Oscar. That's what did it. I'm very bad at reading 250 pages. I just don't, it seems. But these snappy reflections of yours, they are very, very consumable, very readable. And of course, if anybody wants to dig in later on, you can always find the background, right? And the advantage today here is that we actually have the people of the Evaluation Office with us. So even if we want to know more, we can call them, we can be in touch. So today we're looking at all the evidence they have collected and synthesized on the health. And this includes all kinds of Ebola stuff, all kinds of stuff in the past that's relevant for our crisis COVID response now. I think this could be very exciting. And I pass the microphone to Oscar to kick us off. And after that to Heather, I think, who did all the hard work on this particular one. Oscar, welcome and over to you.
Thank you very much, Jan Thomas. It's a pleasure for us to be in this webinar. COVID-19 forced us to rethink our program of work. After a thorough feasibility assessment, we decided that it was not possible to conduct some of the country program evaluations, and we canceled them. This decision freed up human and financial resources to undertake knowledge products that would facilitate UNDP response to COVID-19. So we gathered information of UNDP response to previous crises. We wanted to learn how we did it in the past, what worked, what didn't work, and why. And we analyzed crises such as the Indian Ocean tsunami of 2004, the HIV/AIDS, the Ebola crisis, SARS, avian flu, to name a few, in addition to the work related to earthquakes and hurricanes. So we developed what we call rapid evidence assessments. These are simplified versions of systematic reviews. They looked at evaluative evidence produced by IOE and UNDP decentralized evaluations from 2002 to 2020, with a stronger focus on the last 10 years. We have an evaluation resource center, which is a repository of more than 5,000 evaluation reports. So we did a very rigorous screening process of these evaluations. Each paper reviews systematically around 30 evaluation reports from which they extracted lessons. Today, you will hear our findings from UNDP support to the health sector, which my colleague Heather Bryant will be able to present later. This is a very rich evidence. Our focus has been on lessons learned and the replicability of these lessons to facilitate its use in the response of COVID-19. And of course, we had our colleagues at country office as our main target audience. With this brief introduction, I would like to pass the floor to Heather. Thank you, Jan Thomas.
Thank you, Oscar, for this introduction. So as Oscar has explained, this presentation focuses on lessons from the health sector. We reviewed a wide range of evaluations. In fact, we looked at 149 country program evaluations, 46 past thematic or corporate evaluations, and we also looked at a little more than 75 decentralized evaluations, looking for lessons in this area of work. And we found interesting insights, not only in evaluations in the health sector, but also in evaluations of other work such as governance, where there have been initiatives to improve service delivery or reduce corruption, which have also included pilots in the health sector. And through this review, we identified 9 lessons. And here I'm just going to present 4 of them so that then you can go find our paper and read the remaining 5. The first lesson is simply that procurement services often require complementary capacity development. As you all know, UNDP has extensive experience in procurement of medicines and other healthcare products, especially through the Global Fund, in many countries. And here I just cite some countries for which we have recent country program evaluations that discuss this: Angola, Cuba, Equatorial Guinea, Guinea Bissau, and Zimbabwe. A key benefit of this support is a significant reduction in prices and even lowering transaction costs throughout procurement lines and the health services chain. Evaluations also highlight the importance of providing support beyond procurement. For example, to inventory management services for medicines and supplies, as highlighted in last year's Guinea Bissau country program evaluation. Overseeing internal distribution to drugs to eliminate drug stockouts, such as we found in Zimbabwe in 2015, and addressing weak infrastructure, such as challenges related to electricity and storage facilities, as identified in a recent evaluation in Mali. A recurring theme in these evaluations is the need for sufficient capacity development to ensure sustainability. So here the message is that even in crises, country offices should focus not only on the efficient delivery of medicines and other goods to counterparts, but also on supporting the establishment of robust national procurement systems that are open, transparent, and bring savings to the country, such as was recommended in the Azerbaijan independent country evaluation that we did last year. The second lesson I would like to expand on is one relating to digital technologies. Our review of evaluation demonstrates that mobilizing capacities to leverage digital technologies can contribute significantly to improved health system management with positive side effects. The country program evaluation last year in Guinea-Bissau highlighted how using mobile tablets to conduct real-time monitoring of local health centers helps map, track, prevent, and treat malaria outbreaks, as well as coordinate rapid responses and improve overall national data collection. A recent evaluation of Bangladesh's Access to Information program highlighted that UNDP has provided support to the implementation of a telemedicine solution developed by a group at Dhaka University. 30 Union Digital Centers now offer medical consultations through computer or smartphone. And we thought this could be an interesting model for the current crisis, where at least initial consultations could be held so a patient doesn't have to travel to and wait in a health clinic unless it's absolutely necessary. Another evaluation points to work in India, where UNDP supported the establishment of an electronic vaccine intelligence network, which built on the government's existing vaccine stock management and supply chain system. This electronic network digitalizes entire vaccine stocks and tracks their movement to all the cold chain points in the country, along with their storage temperature. This intervention resulted in a decrease of the stockouts of vaccines from 10% to 1%, and in considerable savings by substantially reducing the number of out-of-date vaccines wasted. What I found particularly interesting was that in addition, the project had positive side effects in terms of better record keeping, promotion of a transparent and accountable real-time system, use of the management information system for decision-making, and even introducing older women to the use of IT through smartphones. However, despite this last success with women, in other situations, evaluations point out that access to technology, infrastructure, and/or literacy levels have made it more difficult to reach women and vulnerable groups, including people living with disabilities, with digital solutions. Thus, digital technologies need to be introduced in line with the country capacities. Another lesson from our review of past evaluations is that ensuring health workers are paid in time expands care. This is fairly intuitive, but perhaps less immediately obvious is that paying health workers also has positive effects on local economies and access to financial services. As we all know, UNDP gained significant experience with emergency public service sector payments for healthcare workers in West Africa in response to the Ebola crisis. The program retained health workers during the epidemic by ensuring that timely payments and hazard incentives were provided to about 50,000 frontline workers. In another context, Zimbabwe's harmonized health worker retention scheme has demonstrated that retention allowances reduce vacancies and allow expansion of care. And the digitized payment system used in Zimbabwe also had the unintended benefit of bringing health workers into the formal banking system. Receiving payments require them to open bank accounts. And so this suggests that there's a lot of potential to coordinate similar interventions in other countries with programs on inclusive finance and mobile money that may already exist. In addition, ensuring payments to local workers can help boost the local economy, as was demonstrated by support to police salaries in the Central African Republic. The last lesson that I'll mention here is that collaborating beyond traditional health sector partners can bring additional benefits. A key example is again from the Ebola crisis. UNDP successfully partnered with UNCDF, not an agency we usually think of when we're thinking of the health sector, on the Ebola worker payments project in Liberia, Guinea, and Sierra Leone. UNDP program management skills were combined with UNCDF technical expertise and World Bank capital to provide successful and innovative partner payment solutions. Our evaluation of the strategic plan and global and regional programs in 2017 found that the project was widely recognized as having helped to maintain Ebola health worker services at a time when any interruption could have been catastrophic. Indeed, the project was so successful that Liberia and Sierra Leone have joined the Better Than Cash Alliance, in which they're working with UNCDF to digitize a wider band of government salary payments. So again, here the message is to look beyond traditional partners when you're developing new and innovative programs. So I'm going to stop here. You can find more in the full paper. And we have here in the slide links to our website, to the full paper and the whole reflection series. And of course, the Evaluation Resource Center, where, as Oscar mentioned, we have more than 5,000 evaluations, including, of course, those that I've cited this morning and the ones that are in the paper. And so with this, I will bring the slides to an end. And we have a colleague with us today from the Guinea Bissau country office who may be able to share some thoughts from somebody working in the health sector and working in a country office on our reflections paper and what we got right, what we might have missed, and how the work is going forward. Thank you.
Now the name of our colleague just escaped me. Who are we going to have?
George, we have George.
Please, the floor is yours. Oops. Where is George? George, we don't hear you.
Greetings from Guinea Bissau.
There you are. Welcome.
Yeah, I know. I'm having internet problems. Okay. Thank you very much. And greetings from Guinea Bissau.
George, maybe it's better if you turn off the camera. It's beautiful, but maybe without the camera we can hear you better.
I would have some comments related to the various presented by one city in place.
George? George? George, can you turn off the camera because the sound is very bad.
We have the added advantage of having...
George, can you turn off your camera? Then we can hear you better. George, I'm suggesting, yes, exactly. There you go.
Perfect. All right. So, can you hear me now?
Yes, please.
Perfect. So in those countries where he does have a fund project management unit, capacity development in place, meaning having human resources specialists, procurement supply chain specialists. And in addition to that, it's the HIST unit or team at the headquarters, part of the Global Fund Partnership, headed by Tracy and team. Related to point number of I'll get back. Focus on health services to reduce barriers to access. Here is to reinforce community health workers. Essentially, community health workers as a firewall between 80% of morbidity, which is at the community level, and then the more complicated cases. And here there's also, for example, Nepal, where there were 50,000 health workers trained, did outreach mortality over the
George, I'm afraid it's not working well enough. We can't follow you. George, we would like to propose that you... George? George, we will propose that you bring your interventions either in a file.
Yeah.
You can send us a sound file, or you can write something of your input, because the line just doesn't carry you at the moment. You were referring to a number of interesting practices about community health workers. I see you were also referring to the team in UNDP that provides support to our medicine procurement. I don't know whether Tracy is in the room. Otherwise, Mandeep, can we have a quick word from you on what you think is the most salient thing that you heard today on the evaluation evidence?
Okay,
What have you read in the paper of the evaluation office that was struck you as significant? Mandeep.
Thanks so much, Jan Thomas, and I'm sure Tracy will come in as well. I know she was planning to attend, but I think the couple of things that come out, and then I think what we were hearing from our colleague before his internet connection went bad was that you need to have the specialist capacity to be able to support the PMU and the country office colleagues on what are quite technical areas. For example, the procurement, supply management. What I thought was striking was that even though these evaluations are retrospective, the highlights around partnerships beyond the health sector with World Bank, with civil society, with others are critical. And I think that's going to be really important, and we're seeing that it's already very important in the context of COVID. The other interesting lesson, of course, is around digital and how in a country like India, you can go to scale with digital fairly rapidly, and the use of digital in otherwise what was a very challenging problem, which is the increasing the coverage of routine immunization. So I think some of those lessons are particularly relevant for the COVID response as we evolve into 2.0. I think the business continuity, the public services, looking at areas that are sometimes outside the traditional health sector, for example, payment of health workers is another interesting area where we can draw on capacity from across the organization to help countries. I just want to say that a lot of the examples in the paper, which I think is superb, it's excellent, and it makes me think that I'm going to start and explore the evaluation website a lot more now. So I thank colleagues from the evaluation office for sharing that. But some of the really interesting stuff comes from long-standing partnerships with the Global Fund, and that's the team that Tracy leads. We have deep capacity there to work on health system strengthening, and we've been able to leverage that, as we can see in this paper, for Ebola, and we're now leveraging that capacity to support also on COVID. And it's not just the team in Geneva, of course, it's also the PMUs in countries. It's also the GPN roster, which has over 350 health experts, which we're constantly trying to update so that we have the latest. And I'll end on the final thing, which I really liked in this paper, which was about engaging people with disabilities in the development of strategies. And I think certainly in the context of HIV, TB, and a lot of the health work that we do, we know that it's actually by involving and engaging those who are most effective that we get the best quality services and support to our beneficiaries. And UNDP can play a really important role there in bringing those voices together with government, together with the private sector. So the convening role, bringing in the most effective people to ensure that we are delivering quality services and reaching those who are left behind. So I'll stop there. Thank you, Antoas. I'm not sure if Tracy may want to come in as well.
Thanks so much, Mandeep. I mean, you refer to capacities that we need. Messing around in the health sector is not for amateurs, right? Certainly not for people who don't know these things. You have to know the medicine, you have to know the systems, you have to know health. And the good thing is that here in the room today, but in the organization at large, we have all those resources, right? If you call in, if you find yourself in a situation where your government is wanting, where they say, I can't buy my own medicine, can you do it for me? This organization has a wealth of resources, not only on the narrow path of health, but on all those tangents that Heather collected for us from evidence, whether it's in payment systems, in digital systems, in stock systems, etc., etc. So UNDP is a very rich organization in that respect. I have a question from Ruben here.
Thank you, Jan Thomas. Indeed, I just wondering to what extent the collaboration or any competition is their experience with traditional agencies such as WHO, Global Fund. In the Western Hemisphere, we have PAHO, WHO. Because traditionally, these are the agencies that are taking the forefront in addressing health issues. But as UNDP now also enter into the scene, what is the experience based on different evaluation? Is there a fact that we adding value or and collaboratively reach better results, or are we competing at the same scene? Thank you.
Very good question. Who wants to take that one up? Heather?
Okay.
Maybe I can just take it up with respect to a review of the evaluations,
Yes.
and then somebody else could pick it up with respect to what's happening now with those working in this sector. My answer, and many thanks, Ruben, for the question. It's a very good question. To be honest, when we were reviewing the evaluations, a lot of this collaboration and cooperation comes out as sort of being, I don't want, this sounds wrong to say take it for granted, but generally the evaluations speak of good collaboration, but without going into a great deal of detail. And so I didn't come across any discussion of this question of competing for resources. But I think that's a really interesting point. So maybe when we're doing another round of these, we can have that question in our mind to look and see if there's any evidence in the evaluations in that regard.
Well, we have Tracy in the room. I'm sure, Tracy, this is one that you are living on a day-to-day basis. Competition with other agencies and the exact added value of UNDP in the room of health support, procurement, and others. Tracy, we do see a background painting, but we don't see you.
Okay, I'll stand up. Hi, everyone. Thanks so much. And really a huge thank you to the work of the evaluation officer. The paper is just excellent, and we'll be able to use it widely in the advocacy in support of our work. In terms of competition, I think that the amazing results that UNDP has achieved in the area of health and development has really been in partnership with other agencies, WHO being a normative agency, and also with PAHO. And so really it's through this partnership that we're able to achieve the results. So it's really not a matter of competition, but it's each entity identifying its comparative advantage in the health sector. I think what UNDP brings is really the success in the health sector is really our operational implementation support. And then also as you mentioned at the very first slide, is the capacity development and the sustainability. And then also the strong policy work, which cuts across, whether it be human rights or governance into the environment, climate. So it's really that three intersecting areas that is UNDP's success. But, you know, of course, it would be naive to not acknowledge that at the country level, you know, of course, there's agency competition. And I think that that's something that we've addressed over the years in really putting together guidance notes and you know, case studies and where there's good examples of agencies working very well together. I mean, we've just had a situation in Haiti where we've submitted a proposal to be the interim principal recipient there. And that proposal was submitted to the Global Fund with IOM and World Food Programme. Maysoon is on the line. We've also got a very successful TB program in Pakistan, Afghanistan, and Iran. And again, that was done with IOM and also with WHO providing technical assistance. So if country officers are being presented at the country level that there's competition with different agencies, our team can certainly provide very good examples where there's great partnership across the UN family. Thank you.
Yeah, sometimes we assume competition also. Huh? We have to be careful. I mean, when we were procuring medicines in Ukraine, first the government went to the WHO, and WHO says, no, we're not going to procure medicine. We think it's very risky, we can't. Then they went to UNICEF. They said, UNICEF, yes, we can procure medicines, but these 5 medicines. But they said, we need 200 more medicines. So no, and UNICEF said, no, we can't. So before you know it, you have a niche, right? Without competition. But we need to have very open lines with those agencies, of course. And more often than not, you see that is a niche for UNDP. Not only just in procurement, of course, but in many other areas. But don't assume also. Don't assume yourself out of the market in some way, because we have capabilities that are fairly unique, but they come to bear in different shapes and forms in your particular country. So that's where you need to keep an eye on it. And the moment you have a lead, you call one of your colleagues, right? All in the room here today, from Tracy to Mandeep to the evaluation office that can point you to those people. Moreover, I mean, every country office that has global fund implementation has a thing or two to say about this, right? UNDP is a very rich environment, knowledge-wise in this, and you're not alone. And that is the message here today. We have time, of course, not too much time. We have time for one more question. Maybe I'll just throw it open. We see that George in Guinea Bissau is actually writing his lessons learned now, his evaluative. He already has more than you had, Heather. So, I mean, the 9 lessons are coming out. We'll compile them nicely in a document. So we make sure that, that we take note of it. And anybody else, I mean, I'm sure on a one-to-one basis, the line with George will be can be better than what we had today. We were a little bit unlucky. I still have time for one question, impromptu. Or do we have one still in the chat, Polixenia, or I'm missing one?
Maybe Abhilash would like to ask the question.
Yes, Polixenia, thank you. So the question I have, maybe it was documented in lessons, but the document is big, that's the reason I'm not able to hear it, read that. But does the lessons learned also capture the lack of health access among the indigenous tribes? Because that was the bigger problem Brazil, Peru, or Chile is facing when it comes to COVID-19, is because there is no, the thing which you are talking about, the digitalization or any of the, they don't have those things. So we need some other way to reach them. So does lessons learned capture that aspect as well?
Thank you, Abhilash, for that question. I didn't find specific references to reaching indigenous peoples in some of the countries that you mentioned, but one thing that comes out in many of the evaluations is the importance of working with local organizations for community outreach, to be able to pass messages in local languages or using appropriate means of communication to reach people. So the paper touches very briefly on that, and there is more in the evaluations that are cited on the importance of that level of outreach. You need to work with partners at the community level. And George also brought that up when I was speaking with him before the webinar, and he was reacting to the paper. He said, on lesson 6 on women, you missed the community level outreach. That's really important. And I see that he's posted again in the chat the importance of community level health workers who represent a firewall between not complicated health problems, about, he says, 80% of the cases, which can be treated at the community level, and the health system, the health centers and hospitals. And so that's not true. It's not only true for women, but it's also for other people who may not have that access, but you do have to have that means of communication so that they have the information.
Thanks so much, Heather. Oscar, you want to add something?
Yes, indeed. I just want to point your attention to a guidance note developed by PAHO, the Pan American Health Organization, and the World Health Organization on health disaster risk management with indigenous peoples, which was released in 2019. So a few months before the COVID-19, and so it might be a useful reference for dealing with those sensitive issues. Thank you.
Thank you so much, ladies and gentlemen. I think this was rich. We want to congratulate the Independent Evaluation Office on this snappy stuff that we can actually use right away, and we don't have to wait for 2 years to have it. Heather, that was a great job. I'm very glad I don't have to read those 5,000 evaluations. I can just read your document. Ladies and gentlemen, look around the room. Here's Richard as well. I see Alan, all from the Evaluation Office. But also please see our other offices that have health programs, that have procurement programs. Tracy is here, Mandeep is here. Find each other, because the opportunities abound and we have to be very alert of it, and don't let them go. Don't think I don't know anything about health. How can I? It's because you have a whole organization behind you that you could stand up to the Minister of Health, say, well, please, maybe we can have a shot at this. Let me call one of my friends. So that is the function of these webinars. We're just touching on a subject. We can go deeper. We can read the materials of the evaluation. We can even go into their database. We hope to have the evaluation office around also next week and the week after, because they have done 4 of these reflections, and all of them are, well, they were selected to be relevant for COVID. So Oscar was playing it clever, but he will have a session every week from now on so that we can also touch on the other subjects that some of his colleagues have dealt with. Ladies and gentlemen, this is the time where you can turn on your camera and say hello to your neighbor next door.
And Thomas,
and the final words are for Oscar.
Yes, thank you. I just would like to invite colleagues to participate. The next one will be on social protection. A number of countries are now really expanding their scope of social protection programs. The following on livelihoods and job creation, and the last one on governance of this first series of reflections. Thank you for your.
There you go. And tomorrow, Polixenia, it's not the evaluation office, I hope.
No, tomorrow we're going to talk about international futures to model impact of COVID for SDGs. We're going to have our colleague Laurel joining and a guest from the Center for International Futures, a professor.
So modeling the impact of COVID. That will be exciting as well. So stay with us every morning, 8 o'clock Brooklyn time. Ladies and gentlemen, turn on your cameras and say hi. See you tomorrow. And thanks to our rich resource persons. Well done.
Thank you so much. Thank you. Bye-bye.